Hello and welcome to Past the Scope, the official podcast of Scope Education. This is FOAMed for providers who believe learning shouldn't stop at their job title. Join our team as we explore high-impact clinical topics and insights that elevate your care, no matter your scope of practice. The content you are about to hear is based on medical fact, and the opinions of hosts and guests do not represent their respective employers. Remember to always follow your local respective policies and scope of practice. Now sit back, relax, and let's go past the scope. Gentlemen, thank you for coming on. For the listeners, I have Dr. Piehl and Dr. Antevy on here. So excited to have you gentlemen on. This is a treat for me. And yeah, I just can't wait to get into it. How are you gentlemen doing today?
Great. Yeah, privileged to be here. Thanks for inviting us. I know Peter's on the road, so.
Yeah, I'm on the road. Don't worry, I'm in the right lane. My eyes are on the road. But Jake, great to be with you, and really excited for this podcast.
Yeah, and knowing Florida, you're going about 90, right?
You know what? I was before the call started. Now I'm 55.
Listen, I've been to Florida enough times that I know the highway driving is pretty crazy down there.
Yeah, it is.
All right, so we're going to be talking about some peds resus today. Some different topics. Somebody asked me to talk about blood, but I said because Mike just recently published that episode about blood, as much as I would love to talk about it, there's some other things that I think we should hit on. Yeah, the blood thing is pretty big topic.
If we have time at the end, let's do a quick blood recap, but you can link out to Mike's podcast because we did just talk about that. So
absolutely. Yeah. So for those that don't know, Dr. Piehl is a peds intensivist. He's at Wake Med. He's also the medical director for Mobile, right? Wake Mobile.
Assistant medical director I help oversee the children's team of Wake Med Mobile Critical Care. Yep.
Gotcha. And then Dr. Antevy's a PDM and EMS doc extraordinaire down in Palm Beach County, Florida.
With the biggest budget in the world, you know it.
Yes. The biggest budget in the world. I always say one of my ideal medical directors, and that's not to blow smoke. That's
Come on down. Hey, Florida, we're hiring, baby. We'd love to have you.
I don't know about the heat in the summertime. North Carolina is enough for me.
it's the summer is miserable. Let me tell you, we want out in the summer, but I don't blame you.
Yeah. All right. So without further ado, we'll get into it. So the first topic I have is atropine and peds RSI, and we're going to talk specifically about peds. We can touch on the neonate topic, but specifically with pediatric RSI. What are your opinions? What's the prevailing evidence? I've heard kind of debates on, or different opinions on, we use it, we don't use it. So what do you say?
I'll let Mark go first. He's the guru, but I think he and I are going to agree. But go ahead, Mark.
We're going to agree. I'm not sure I'm the guru, but I do love airway management. I love talking about these controversies. So bottom line up front is I never use atropine, and I don't believe that there's any evidence that supports its use, with maybe one or two caveats. Okay. So why would we use it? The idea is we're preventing bradycardia from occurring during the intubation, right? And what are the reasons the bradycardia occurs? Mainly it's hypoxemia. It's taking too long to look, letting the child desat, and then allowing bradycardia to occur as a result of hypoxemia. So there are other ways around that, which we can talk about. Number two, the stimulation of the airway with the blade conceivably could lead to bradycardia, particularly in babies. And so I think that's why historically atropine has been used. So to me, if we use the right induction drugs and paralytics, we probably don't need it. Number one, I'll talk about those. Two, it's just one more thing to give. How many things do we want to pull up and dose correctly? The fewer the meds, the less complexity, the better. So if there's not a need for it, why bother?
And what I'll add on just real quick, Mark, because I 100% agree with you, is that when you're intubating a child, one of the best markers of whether or not this kid's not doing well is their heart rate. If you're artificially bumping up the heart rate with a medication, you now don't understand what's really happening with the kid. And I've seen this over and over again many years ago when I used to use this drug, is that so if you do not give a kid atropine and you're looking in the trachea, you're looking for the cords, people are digging around in there, and all of a sudden you can see the SATs going down, but the heart rate will also drop. And that's when sometimes you or multiple people have to say, hey, let's start bagging this kid again, buddy, right? when you have atropine on board, you lose that bradycardia as just another symptom of badness because you're artificially elevating it with atropine. So that's just another thing to add on to what Mark said.
I think of it like adults that are on beta blockers and they're septic and their heart rate's normal, but they paint the picture of sepsis, but you're like, their heart rate's in the 70s. Why?
Yes.
Correct.
Exactly.
And usually it's going to be hypoxemia. So a couple solutions I would propose. One is practice airway management. It's requires reps in simulation in particular. I like using a hyperflexed blade like a glide scope or a McGrath. I know Peter's team has just gone to that for all their peds intubations. I think it's less noxiously stimulating to the airway than a straight metal blade. And most importantly, I think the choice of your induction agent. And so my choice would be ketamine in any age. I know there are fewer data in this for neonates, but we're talking peds here. I would choose ketamine. What are the benefits of ketamine? It's going to increase your heart rate slightly. It's a sympathomimetic. It's going to completely anesthetize the child so they're not perceiving that noxious stimulation of the blade. And I think you're not going to see bradycardia unless you get down the path to hypoxemia. How do you prevent that? We're going to pre-oxygenate, obviously, and use apneic oxygenation with the intubation. So, Jake, we could talk about airway management the entire podcast. I know we don't have time for that, but I think those are the basics. I also use rock. There's some evidence potentially that succinylcholine is more likely to be associated with bradycardia in children. And so some people recommend, if you insist on using sucks, that you add atropine. In that case, I'm not going to argue with that. I just don't use succinylcholine. I don't see a role for it.
Do you
Peter?
think that has to do with the fasciculations, or is there another?
It may stimulate the vagus nerve. It may be fasciculations. I don't actually know that mechanism, Jake. I'm sorry.
Hey guys, the other thing I would love to mention, because it just came out, I just heard a Weingart podcast on it, but have you guys seen the RSI study?
I just listened to that podcast yesterday.
Right. So Mark,
It's in my queue. I have not listened to it yet.
Yeah, you know what? And it's very interesting because, Weingart is a big DSI guy, converted all my agencies over to DSI, but all of these patients were RSI'd, and they had about just a people in the pockets. I don't have the exact numbers in front of me, but there was about somewhere between 17 and 22% of the patients in either the etomidate group had a lower incidence of hypotension, but the ketamine group had a significantly higher incidence of hypotension. And they used 3 different dosages, 1 per kilo, 1.5, and 2 per kilo. But across the board, ketamine demonstrated a significant incidence of hypotension. And this is, again, within 2 minutes of the tube passing the cords. Scott did talk about DSI in there, but it's going to make me want to go back and look at my own data because we strictly do DSI. We strictly use ketamine and rocuronium, and we're using 2 per kilo. But very large study, thousands of patients, very well done study, but just interesting.
Peter, is there a chance, and I haven't read it, and Jake, maybe we're going to have to do episode 2 once we're up on this study. Is there a chance that the patients who got ketamine were under-resuscitated, meaning people gave ketamine thinking that's all I need. I didn't resuscitate adequately ahead of time. And therefore, once you put the tube in, the cuff's blown up, and you increase the mean airway pressure in the chest, they subsequently become hypotensive because they were inadequately resuscitated. Is there a chance of that?
100%.
Or did you get into that much detail, Peter?
They did not. And I was surprised that he didn't, because obviously during DSI, that's when you would resuscitate the patient more so. I thought Weingart would get into that deeper because that's, he wrote the first paper, Jarvis wrote the subsequent ones.
Yeah.
Oh. Yeah. I agree with you 100% that they, at least according to the podcast, and I thought Weingart would harp on that a little bit more because he wrote that initial paper, Jarvis wrote the subsequent papers, but there was no mention on the podcast, at least, because remember, because they're doing RSI, they're not giving ketamine, waiting 3 minutes, resuscitating the patient, and then throwing on a paralytic. They're going either etomidate ketamine and then the paralytic right afterwards with a flush, and then they're intubating. So I have to dig into the paper itself, but after reading and hearing the podcast, I had the same question as you did, Mark. I don't know the answer. Maybe Jake does.
I will say Josh Farkas just posted today on Pulmcrit kind of a rebuttal to the Weingart podcast and to that study.
What did he say?
And it basically, he had some little tidbits of maybe physicians gave vasopressors kind of empirically in the etomidate group because they were anticipating a drop in blood pressure versus the ketamine group, and so maybe that had some effect on the data. Definitely, I haven't read the full study yet because I haven't gotten access to it, but I definitely want to. But that, yeah, Josh Farkas did a very good rebuttal, I think, pointing out some key points.
Yeah, what was interesting, and I have to read that because I think that's so true, that without understanding exactly what happened on the per patient level. However, in summary, what Weingart has said, and Weingart's a DSI guy, he said that he's only going to DSI certain patient types, and they're now, based on this one study, going to trend toward etomidate. But I don't know about you guys, I'm still a big DSI person, and it's going to make me want to go back down and look at my last 12 to 24 months of data and do an evaluation on a much smaller scale than these thousands of patients. But I got to read that Farkas paper, the rebuttal.
Yeah, no, it was really good. It's on PulmCrit on his website there. So yeah.
Peter, do you want to do a quick review? We lost most of what you said because of your signal.
Yeah. Let me answer the question with respect to the actual patients. And they're, at least on the podcast, they did not have anything to talk about whether or not those patients were resuscitated and how they were resuscitated. And that's why this Farkas paper, where he says that, hey, potentially these physicians, but which, by the way, they were allowed to do whatever they wanted to do clinically. And if they were giving pressors because they said, hey, I'm giving etomidate, and maybe I should give a pressor with etomidate and not with ketamine because of what they thought ketamine would do,
Correct.
Perhaps that would skew the outcomes. Weingart and the authors did describe that they're still going to be digging into some of these subgroups. But what I had mentioned earlier, which maybe got cut out, is that because they're not doing DSI, they don't have that 3 minutes in between to resuscitate the patient appropriately and adequately. So I still need to know more. And it sounds like I'm more on the Farkas side than on the Weingart side for right now, anyway.
Yeah, it'd be nice to know if they're using like push dose pressors versus a continuous infusion, and what they're using specifically for pressors too.
Correct, and whether they adequately resuscitated with blood and/or fluid ahead of time. I think that's an issue. I will add, I agree with the DSI approach, the delayed sequence approach. Ketamine will remain my choice. There's a large multi-center study in children called NEAR for Kids. It's a multi-center database of intubation practices. And in the largest output of that study group on induction med choice, ketamine of all meds was associated with the fewest hemodynamic adverse events. So we have data in kids that ketamine is likely better in shock and out of shock. Number two, I did just quickly research while I was listening to Peter simultaneously that the mechanism of sucks causing bradycardia is through the stimulation of muscarinic receptors and automatic ganglia. So there is a direct neurologic stimulation of nerve fibers when sucks is used, particularly in children, that may precipitate bradycardia. So in those cases, if you insist on using sucks, atropine may be your friend. Otherwise, I would just stick with ketamine and rocuronium.
Gotcha. Well, that's what I wanted to know, because like I said, I've heard kind of in both directions that we should be using it, shouldn't be using it. So I'm glad to hear that is maybe not the official take, but that's the take of both of you. So
right.
Awesome. That was a great discussion, and we got off topic a little bit, but I love those. I mean, if you listen to Mike's podcast, that's rabbit holes are a favorite. They lead to some really good discussion. So next, I wanted to talk about some CPAP and non-invasive in kids. So what are some pearls that you both would say for that? And do you use high flow more so in the ED and ICU setting versus the CPAP or non-invasive?
Yeah, this is a fascinating question. I'd like to hear Peter's perspective as a medical director in his agency versus what we tend to do in transport, ED, and ICU. So there's definitely some overlap in the concepts of NIV, CPAP, and high flow. They all provide some measure of positive pressure to the airway, okay? We typically use, in my setting, high flow nasal cannula oxygen, up to some amount of liters, okay? You were probably used to, during COVID times, adults are getting up to 60 liters of flow. That provides positive pressure Not only does it provide increased FiO2, it provides positive pressure to the lower airways. In kids, and little ones in particular, we tend to start with a 1 liter per kilo of flow, okay? So imagine a 20-kilo kid could get up to 20 liters. And that tends to be our first line. We'll convert to a NIV, a cannula that's more occlusive in the nose, and apply either a CPAP or a BiPAP through that. But I think we've improved care and reduced the need for endotracheal intubation in kids with lung disease dramatically over the last number of years that we've begun to use all these therapies and high flow in particular. But Peter, what do you do in your agency?
Yeah, first I'll say that I agree that in the ER side of the house, it's high flow all the way, and that's it's something that's become routine. This is many years now already, and there's some EMS systems, not too many ground 911 systems who have the availability, but now with I just switched over to the T1s, and obviously with the T1s we can do it all. But I will say that what I'm pushing now, because I met some folks out of Ohio, a gentleman named Kyle Goodnight and Chelsea Kadish, he's the PDM doc. And for a long time, CPAP was never used in kids because when you look at the actual masks themselves, they just were not made for the younger kid, and you couldn't get them on, and the kid would not want it on, and so no one ever used it. They have then created these masks that go from the top of the forehead to the bottom of the chin. It looks like a big scuba mask.
Right.
And so the only problem then is that you have to put together all these pieces in order you have to have the elbow connector and all this other nonsense. I did a whole webinar on it. I did 2 webinars on this already. And people keep calling me and they're like, how do we put that damn thing together? Because if you can use it with the disposable devices that we already have for adults, it's a winner. So lo and behold, Intersurgical met with Kyle and Chelsea, and they've actually now created, and again, I'm not getting any money for this, whatever. I don't know anything with Intersurgical, but I actually went and visited them during EMS Expo, and they showed it to me where now they now created a mask with all the parts and pieces all in one, and all you gotta do is add it on, just add the mask on into your onto your ambulances, and you have pediatric CPAP that actually works. So we are now making the big push. I've had all my agencies now move towards it. And so I'm a big believer that in EMS, you should be using a disposable CPAP system. And whether you use the one Matt and Intersurgical makes or you put the pieces together, it's so good for things like, especially things like drowning, right? Non-fatal drowning, where you get there, the kid's not in cardiac arrest, but the kid's having respiratory distress. You hear valves, they're satting at, let's say, 75, 80%. And someone says, hey, let's intubate that kid. No, put them on non-invasive and drive them to the hospital, and they can get definitive airway there. So I'm a huge fan of this, and I think that most EMS systems out there should be looking at it. And that's what I got to say about that.
Peter, my only question is, do you always need the full face mask interface, or would the high flow / CPAP nasal setup work? To me, it's better tolerated. I know that the folks you mentioned have had good success, but I think that maybe both could be options.
The only problem is with that is that no one's carrying the high flow setup. I mean, now we are in Palm Beach County, right, where I have them on my EMS captain as vehicle, but I think that you can get this pediatric CPAP, this disposable version on every single ambulance, right? It's driven, like the actual driver, it's just off the O2 tank. You don't need any special equipment. Whereas for the high flow nasal cannula, you do need expensive equipment.
Correct.
That's my only downside there.
What are you doing in Wake EMS, Jake?
We actually don't really have CPAP
Okay.
for kids, unfortunately. That's something that
Nobody does. No, nobody
really
does.
spurred this conversation, was that we
Maybe
don't
you
really
need a
have a good
pediatric
option.
medical advisor who's local to kind of work with you on that. So,
No comment. No comment.
all right.
I know a guy.
Next topic.
Yes, I know a guy. I know a guy now, especially. Right, so that's great. IOs in kids. This is a hotly, I think in some circles, hotly debated topic, particularly the site that we're using.
Yep.
So I wanted to get into the site, the size, and can we use the drill in infants? Because those are three common ones. So we'll start with
Yeah.
the preferred site for peds IO.
I'll start because
You
we just
start.
published our paper. Yeah. There's no doubt that you should not be using the proximal tibia in children. It's just there's a paper from 2019 which I've made videos on that showed that especially in infants and in pediatrics, it's about a 50-50 chance that you're going to get that thing correct, right? Because if you just think of the surface area of the proximal tibia, and the smaller you get, that bone is so darn thin, and then if you're using the drill, you go right through it. It's also near the growth plate, so there's a risk there. When you look at the femur, the distal femur, it is so darn big, and the cortex is much thicker. Many of you listening to this call, to this podcast, will remember, if you put in enough tibial IOs, that most all of them don't work after a while, and they almost always come into the ER, and they're just not working, right? And the nurses get pissed, the doctors get pissed. When you put in a distal femur IO, go try and take that thing out. It's even hard to remove. So from the location perspective, it's out of the way. It's easy to locate. It's 1 to 2 finger breaths, above the proximal aspect of the patella, right in the midline. And we've been doing it for about 7 years now. We published our data, less than a year ago. And this is the first paper on the distal femur IO. But I'll shut up there, but I would love to hear Mark's opinion, and then we can continue on with the other questions.
Yeah, I love it, Peter. And it's good that you have data out now. That's one I'll have to read. I know you and I have shared this opinion for years that distal femur is better. It does take some training, Jake. And so that's one trick to remember. I agree with the placement of 1 to 2 centimeters or 1 to 2 finger breaths above the patella, straight through the midline. If you look at the easy IO literature, I think they still recommend a medial approach. I think that's a harder approach because you have more muscle there.
Yes.
And so to me, the easiest thing in the world is straight through the anterior aspect of the distal femur. And like Peter said, number one, it's a thicker bone cortex, so it's going to be more stable. Number two, the emissary veins, the veins that really actually come out of the bone and subsequently go into the venous circulation in the popliteal are bigger and more numerous in the femur. It's just a bigger bone. So you're going to have better flow and a more stable access point. And I'd love Peter's recommendations on this, but in my experience, I have noted that where I think a balloon needle, the medium-sized one, is adequate in a kid, it often isn't, because you have more tissue and muscle to go through. Therefore, my general recommendation, I don't have data for this yet, but my general recommendation is if the child's 5 or older, I'm using a yellow needle. I think, Peter, you're around that. Is that around age you're recommending that as well?
Yeah. So
because you need enough needle. Go ahead, Pete.
No, I was just gonna say that just so people understand that it all, and I know Mark knows this, but it all depends on the kid. But we have the smallest kid that has needed a yellow needle in my department is 2. But
okay,
usually it's around 4 to 5 that you need the yellow needle. But just take everything with a grain of salt, because if you're a rice and beans baby, you're going to need a bigger, maybe that 2-year-old does need a yellow needle.
Exactly. This is a good point. Well taken. The way to know, and you know this, Jake, is you take the needle, you don't turn the drill on yet, and you plunge it to the bone. If you have one black line still outside the skin, you have enough length additional to get through that cortex. Okay.
Mm-hmm.
And as soon as you feel it drop through, as soon as you feel the give, you stop. Do you use a drill is your other question? Of course, absolutely. And you get a much cleaner insertion than if you're trying to do it by hand.
Right.
That's what Peter and I did in our early days as trainees in early career. We were putting these in manually, and it was much harder, less precise. You can often go through the whole bone. So the drill is a beautiful thing in my
because
opinion.
a lot of us are told that, like, especially in neonates, that we shouldn't be using the drill. That's like what a lot of us are told.
But hold on, I would say that I would wholeheartedly agree with not using the drill in newborns, and the only reason I can tell you that is because we've screwed that up too many times to count. Then listen, you give a guy a drill, and they're gonna plunge it all the way through. So if it's a newborn or neonate, even up to 2-3 months, those EZ-IO needles, the reason that they had a patent on it for so many years is because they're a cutting needle. I mean, I know Mark knows this because he drilled his own freaking leg. It's on YouTube.
Iconic.
Right. So I would say to everybody listening that if it's a newborn, 1 month old, 2 month old, 3 month old, take your hand, take the needle. If you're gonna go through distal femur, balloon needle on a neonate, 10 and 3, 10 and 3, 10 and 3, which I should might have my hands on 10 and 2 right now on the steering wheel, but I would do 10 and 3, and you'll notice that it's like butter. It'll just slip right in, and you'll have a better feel for it with your hands. So I have made that change in my department.
So I'm not going to argue with you, Peter, although, and you and I agree on most things. This one I'll push back a tiny bit. The only reason why is you can still push it through with that method. I've probably done a lot of them, and so I've gotten more comfortable with it. But if you spin the drill and just gently apply pressure, you'll know when you're through and you stop. If you're stressed and you push too hard, I agree with Peter, they'll go on through. But it's possible to do it well with the drill. We'll leave that one as an open debate. But I guess since Peter's done it successfully in his agency, I'm fine with going with his plan. But you don't need to put the tibia, just do the femur anyway, you know?
Right. But I would say that if they're you or me, and because that drill it's nuanced. That drill is nuanced, and you can't just jam it and throw everybody just goes right through the thing, right? And so, by the way, I wanted to say, we found a doctor out of Colorado, Anna Dema, and Mark Noser, and she created a distal femur trainer, and we actually did a study on it, which we have submitted. Hopefully it'll get published shortly, but it was very clear to us that you do need training. There was never a good trainer out there, so she created one, and we helped her validate it, and it's been wonderful for our agency. So
yeah, I'm so glad you mentioned that.
It's definitely a skill
great.
set.
Yep, and I was going to recommend it as well. If you want to look it up, it's Complete IO. I believe it's available now, Peter, right?
I have no idea.
I think it's available for sale.
So.
It's a very slick, realistic feel trainer that you can actually infuse fluid into, so you get not only the feel of the needle going through, but the feel of the resistance to infusion, which is it's the next trick. So I highly recommend that as a means of effective training.
Gotcha. Yeah, can we all agree that we need to throw the red needle out, the pink needle out?
Yep.
That was, I did a cadaver lab with Scotty Bulliter, who was one of the guys who invented it. And he even said in there, he's like, the only reason we haven't red needle is because the FDA required a neonate needle. And so that's what they came up with. And he's like, just throw that thing in the trash, use the blue and the yellow, and that's fine.
I have a question for the two of you.
Correct.
What's the youngest age in which you'll try a humeral head?
I have heard 12. I've heard different things. I've heard... Yeah, I've also heard some people say maybe 5, but
that's a big spread.
Yeah,
so
exactly.
I'll tell you what I do. When you look at when does the humeral head completely ossify and no longer have cartilage, it's around 10 years of age. So, but having said that, just understand that you can still put an IO in. It's just softer. It's not going to stick as well. So you could really try it at any age, but you may not have the best luck. And it's hard to really palpate that humeral head because it's behind so much tissue. So I don't really like it, to be quite honest. And it gets in the way. So I'm not a humeral head guy at all. I say, and if you miss a distal femur, you probably need to look for another job. It's so easy to hit.
Some places have gone to distal femur in adults. I know Parker County Hospital District in Texas, they've gone to distal femur in adults.
Yep.
Yeah.
San Antonio, Lee County, Florida. A lot of my folks do it now.
So I had a question. Like if someone has too much muscle mass in their femur, what like let's say this is maybe a nuanced thing, but like let's say you have a bodybuilder who has a gigantic thigh. What would that?
It shouldn't. I'll answer that by saying that in Texas, they allow them to do a cut down because it's not really the muscle. Because if you palpate that spot, let's say in the adult, go 2 finger breadths above the proximal aspect of your patella, you realize that all you're going through there is fat and the patella tendon.
Right.
Right. So basically, there's not really much muscle there. You feel like a big divot right there, actually. So it's only the people who have a lot of fat there. I'm not allowing my folks to do cut down. Dave Miramonte does because he's got Scotty Bolliter, the legend, in his backyard.
To train.
Yeah, exactly. I would say that now the EDIO manufacturer is supposedly coming out with a 65 millimeter harpoon. It just hasn't gone through FDA yet. That's what I don't know if you guys know any further on that, but that's what I'm waiting
No.
for.
That's the first I've heard of that, actually.
The one caveat, Peter, I'm also less comfortable personally with the humeral head because I haven't put as many in, but I know a lot of our agencies do it routinely and well, especially for blood. The one caveat is if you have pelvic fractures, abdominal injury, shot in the belly, whatever, is it better to give the blood up in the upper half of the body? Probably is.
Yeah.
I don't know that for sure, but it's just kind of intuitively what I
That's always been my thought, is because also it's closer to the heart, but that exact, if you have a pelvic fracture, if you have some sort of vascular disruption in the pelvis and the abdomen, all that blood's just going to go straight into the pelvis or abdomen.
Well, it's the same thing.
I personally am very, I said I like humeral IOs. I put in at least over a dozen of them, and Scotty was also the one that taught me them. So it helps that he was very good in his teaching, and so I've since taught a lot of other people his method, and it's helped them a lot too. So I personally really like the humeral IO.
Lessons, that's like getting singing lessons from Elvis. I mean, come on.
Yes. Yes.
The one thing I did want to mention is that it goes the same for an IV, right? Because I had a kid in Pittsburgh, teenager, got shot right at the left clavicle, right below the left clavicle. And we erroneously we had a left AC IV, and we're giving blood, and it all ended up in his chest, right? Because right, and that was a mistake. When we opened up his chest, that all that blood ended up on the floor along with his blood volume. So just a word to the wise that you do need to know the anatomy and where the injury has happened, and then choose your IV/IO sites accordingly. Yeah.
Perfect. That's a great way to end that discussion, I think. So my next big topic is something that I will admittedly say I am very hesitant about, because I've heard different people say, oh, in the peds ED, they like to do PO fluids for these kids. Don't stick these kids if you don't need to. Is the fluids in the non-hypotensive kids. Specifically, I have a scenario. I had a 3-month-old with RSV. He's lethargic, but he has good tone. He's still tracking appropriately. He has a respiratory rate of 70. He's tachy. He's mildly hypoxic. He's febrile and with an increased work of breathing. He received PO Motrin at the pediatrician, and I have him on some supplemental oxygen, which is helping him. But this kid's been huffing and puffing for a day or so. His pressure's fine, but he's tacky. And I ended up not giving him fluids because I didn't want to stick him and make him more irritated. So what's kind of from the peds critical care and the peds EM side, what are your thoughts on that?
Let's start in the ER. We'll start in the ER, Peter.
So I am opinionated on this, and I have a feeling where this is all coming from, but I would say I would need to hear more of the physical exam on this particular kid. And there's some other things that you can ask the parents. How many wet diapers? You could look at capillary refill, like just some good physical exam. Are the mucous membranes moist, or are they tacky type of thing? Basically very dry, etc. But listen, in 25 years in the pediatric ER, when a kid's in front of me who's like you described, they're getting an IV anyway. And of course they're getting fluids because they haven't been drinking well. If you have a kid breathing 70 times a minute, guarantee you he's not, taking all the liquids or breastfeeding, because kids are, at least at that age, kids are obligate nasal breathers, right? And all of a sudden you try to put a bottle in that kid's mouth, and now everything's blocked. So they're not going to feed. So if you ask them a few extra questions and you can tell what their real fluid status is, when Mark's going to talk to you about ultrasound and looking at the IVC, et cetera, that's great. But in the emergency department, that kid gets an IV and that kid gets 20 cc's per kilo of fluid. After, and we could talk about it if we want, but this trial that came out back in 2014, the Feast trial, which scared the crap out of everybody, was a total bogus trial, where they said that giving fluids to children made them worse is complete nonsense. Now, I will take the other side of the argument too, that if a kid is a little older and they can tolerate PO and they can hydrate themselves on their own and their vital
Fine.
signs are not off, then I don't care. Then I won't even put an IV in that kid. But if I'm putting an IV in and you describe the child you just described, they are going to get a bolus from me 100%
Using
of the time.
Handtevy to confirm your fluid bolus.
Exactly.
Yes.
So the question is, I agree with Peter, is that kid in shock or is he just miserable? And to me, that one just sounds miserable, right? You said the mental status is good. His insensible losses are a minimum of 1 mil per kilo per hour. Just being febrile and breathing out that hard. It's probably more than that. It's probably double that. So he's losing fluid through his skin and his breath. He's not drinking because he feels miserable and is breathing 70 times a minute. So he's by definition dehydrated. The child will feel better, will look better if you give a dose of fluid. Now, he's not in shock. He's not hypotensive. You don't need to give a rapid bolus in that kid. Put it on the pump, put it on the bag, whatever, and let it go in. He will actually feel better. So I think Peter and I are in alignment. The gray zone is now he has signs of shock. Let's imagine the child is a somewhat altered mental status. The cap refill is 3 seconds. His temp is 104. Could something else be going on? That's the child where there's controversy from the feast trial, Peter. And
well, I will say though, the feast trial was not a sepsis trial.
It was not. So
right.
let's just do it. Let's
the
just break that
scam.
one down.
That's the scam. It was a trial in sub-Saharan Africa where they looked at fluids versus no fluid, and these kids were in a resource-poor environment. They didn't have ventilators, and a majority of those kids had dengue or malaria. What do dengue and malaria do? They cause anemia. So they cause severe anemia, and a lot of these kids had hemoglobins of less than 5. So when you give patients who have severe anemia pasta water, you will kill them, it turns out.
Same as trauma patients.
Right, same as trauma. And then, but even worse, when you look at the control group, I believe it was 20% of the control group got blood.
Correct.
And so it was a total bogus trial. And by the way, if you were hypotensive, you were not randomized. So this was not a sepsis trial whatsoever. And it was a trial that should have said, do not give normal saline to children who are severely anemic. That's what it should have.
Correct.
That's what the trial should have said.
It was a trial of children with severe febrile illness. That was the loose definition. So if you, and Peter and I are going to do either a TED Talk or a podcast or something on this one day, okay? The harms of randomized controlled trials. Why do people look at that study and give it credit? It's because it was randomized, it had to do with fluid, and it had to do with children. Therefore, whatever outcomes there were, people were hanging on to those. It was specifically not a sepsis trial, but most citations that you look at that cite it call it a sepsis trial. So that's been confused. Peter's right. They had dengue, malaria. Many had sickle cell, and very few had bacterial sepsis. So indiscriminate use of fluid in kids with severe anemia who subsequently don't have access to ICUs, oxygen, ventilators, pressors, whatever, bad idea. We both agree on that. The question I think you're getting to, if I understand it, is to whom do we give a fluid bolus that's not just miserable like your kid? Who has signs of shock, septic shock or otherwise, okay? And let's just take trauma and hemorrhage out of this for the moment because we want to give those kids blood. So I would go back to, Jake, what other signs are you looking for in your vehicle when you're bringing that child in? Something's not right. Altered mental status, delayed cap refill,
End-tidal CO2.
tachycardia. What's that?
I said end-tidal CO2.
Exactly. So not everyone's running end-tidal CO2 on their nasal cannula, but I'm an advocate of it. And if it's low, it probably means you have diminished cardiac output, and that's an incredible sign of shock that we need to take into account. So in those cases, even pre-hypotension, so before the child has reached less than 70 plus twice their age, that's a child that needs a fluid bolus. We're trying to capture them within the compensated shock phase and turn them around before they get decompensated.
I think we lost Dr. Antevy.
Yeah, he'll come back.
Okay. He'll come back. They always do.
So does that make sense?
Yeah, no, absolutely. Yeah, I think you're right. That trial muddied the waters a lot, and the common, they can tolerate PO fluids, and I think it was put on a wide breadth that shouldn't have been, and it should have been more, if your child is specifically these things, then yeah, they can probably tolerate PO fluids and they're fine. But yeah, I think that's a great, yeah.
Peter and I cite a study often out of, I think it was Cincinnati, Peter, where the majority of kids who ended up having septic shock were brought in by EMS. And if they were brought in by EMS and ultimately had a diagnosis of sepsis, they were more likely to go to the to the ICU, more likely to be intubated, more likely to be on pressors. And about 2% of them got fluids pre-hospital.
That's right.
2%. So these kids come in with decompensated shock, having not received any resuscitation. And we think that feast trial has kind of muddied the water and made people actually afraid of a therapy that's actually a beneficial therapy.
Not to mention when there's a lot of people afraid of starting an IV in a kid and all those things.
Correct. Now, can you hurt someone with fluid? And neither of us are going to ever deny that. And I often joke that it's the intensivist's fault if too much fluid is given. It's not the paramedic's fault. It's not the ER doc's fault.
Right.
You give a fluid bolus and you move them to me. And then we dump leaders in later. It is possible to overdo it in the ER, and I can talk about the situations in a minute, but that should be more my concern than y'all's. Peter?
What I want to do is I want to throw in some really cool physiology that I'm kind of growing into thanks to people like John Holcomb, which is the fact that any shock state, and any distributive shock state, so septic shock, anaphylaxis, burns, and even trauma, is this whole disruption of the glycocalyx, which is that inner part of the blood vessel. The cells then open up, the fluid starts leaking out of it. So you have, not just in the ER, or forget about the ER, not just in EMS, but then into the ED. By the time they get to Mark in the ICU, those fluids that you think are staying in the vessel are going out into they're going out of the vasculature. And so I think the whole key here, as we go through this conversation, is that you have to treat these kids early.
Yes.
And so if you're an EMS and you said, you know what, the ER is going to do it, they take an hour and a half until they get the IV, they start the fluids. Yep. All of a sudden, that kid, which would have been just happy and smiling if you would have given it, now ends up either on the floor or the step-down unit, or worse, the ICU. It's really speed to treatment is where sepsis management needs to move to EMS. And with our recent study that we just published on antibiotics for sepsis, and the pit stop trial coming out of Canada, Sheldon Chesky's, hopefully it's going to make EMS aware that we are the ones who should be treating sepsis, not just with fluids, which the pit stop study looks at, but also with antibiotics. So that goes for kids and adults.
Yeah. Yep. I tend to think that EMS is a crucial point in resuscitation, that a lot of people don't
100%.
think about. What we do truly matters and truly can turn patients around and impact their ultimate course.
Amen.
So I guess our conclusion is, yes, a patient with signs of shock or severe dehydration needs fluids, and the EMS crew and the ER should give those fluids to them. One question we might bring up, Jake, if you want to add this as a topic, is which fluid? So saline's gotten a pretty bad name for a lot of reasons, and some others are good reasons. It has an acidic pH, and it's actually not a balanced, it's not normal in terms of its osmolality and all that. So is there a better fluid? People tend to go to LR as another choice. There's really not a lot of data in adult sepsis literature that LR is any better than saline. But if we wanted to use the perfect fluid, the nearest to perfect is a truly balanced one like Plasmolite. And I don't know of any agencies, Peter, do you, that are carrying it? But if we wanted to use a balanced fluid with a sodium content and all the other electrolytes that are similar to what we have physiologically, that's probably what I would choose. But I still think LR or saline are probably okay if that's what you have, with one caveat, which is TBI. We don't want to give LR because it has low sodium content. Peter?
Right. Yeah, I agree with you 100%, but even the Plasmolite is just going to leak out. So I think with plasma, which we're now using,
correct.
And we just incorporated into our sepsis protocol, that's going to be fascinating. But again, I think it's got to be early, because once the glycocalyx is gone and the cells are opened up, and they end up in the ICU, and they look like one of your slides, Mark, where you have the Michelin Man. And you have that. Remember that patient you talk about was 9 liters positive on day 4?
Right.
It's because the cells are just open, the fluid passes right through,
correct.
And now you have to spend your time getting rid of all that fluid over time if they live. Right. That's the problem.
But we're not saying that we shouldn't be giving an early 1 or 2 fluid boluses on the first encounter with the patient if we don't have plasma or something else available.
No.
So
100% saying that if EMS misses out on giving the fluids early, then
there you go.
it's detrimental to the patient later on, even hours, even 1 or 2
Because
hours
we're letting
later.
shock persist, basically.
Yes.
This is the same as the whole blood. Do we give blood in the ambulance or do we wait to the trauma bay?
Yeah.
debate?
Right. And we should be taking blood sugars on all sick kids.
Yes.
Correct.
Yes.
That's another thing that
People forget that all the time.
yes,
I have a
they're
little way to remember
hypermetabolic. They
that.
burn through that sugar so fast, and they probably haven't had much PO intake and all
Correct.
those things.
So infants and toddlers have minimal glycogen stores, and they're going to get hypoglycemic under stress. So here you go. A, B, C, D. We want to go through those when we think about when we're considering the management principles in a child. But then E, F, G. Don't ever forget the glucose. So D, E, F, G is don't ever forget the glucose. If you just
I love that.
if you just run the alphabet through your ABCs and then add D, E, F, G, it's don't ever forget the glucose. And I've forgotten it. My team has forgotten it. But just the other night, we had a kid, super sick kid, come in from an outside hospital, and one of my transport nurses told me, "Doc, the sugar is less than 10. I checked the glucose, and it's less than 10. Sure enough, he remembered right away when he got to the patient, I better check it. Don't ever forget the glucose. So,
I love that.
Don't forget it.
Okay, I'm not going to forget that. That's good.
Yeah, I think we should add that to PALS, by the way.
Exactly.
yes.
I've been lobbying the AHA, and they won't bite on that one.
2045. It'll be right.
We're not going to get into the AHA conversation today because that's a whole other rabbit hole.
Keep my blood pressure low.
All right, that was awesome. It was the exact answer that I wanted, and I assumed that I would get out of both of you. That kind of goes into my last topic is pre-arrest indicators in kids. Are they different than adults? Are they the same? And maybe we can touch on the modified shock index, I think it is for kids. Maybe we could touch on that a little bit.
Sure. Peter, you want to start with that?
No, that's all you, buddy. You start with that.
Well, if you listen to one of our recent Instagram shorts with Jimmy Apple, we basically both said that adults are really just big kids. So the pre-arrest indicators are fairly similar between the two age groups. What are they? So obviously, as we talked about in the first segment here, bradycardia related to hypoxemia is a pre-arrest indicator, as is bradycardia related to hypovolemic shock, as in trauma. If someone's heart's winding down, that's pre-arrest. Loss of pulses, loss of the pulse ox waveform, all those things. Loss of end tidal, those are all pre-arrest indicators. They're just similar to things you would think about in an adult.
Yeah. And then also because kids are so, you have to have so many respiratory issues, especially like think of the asthmatic who is hypercarbic, right? Because they're slowing down their breathing. That's not good. And I think a lot of people get fooled by a normal end tidal CO2 in a child who's breathing really fast because they don't understand that number is not normal given the respiratory rate that you have. And then all of a sudden the kid starts to, quote unquote, fall asleep. No, they're not sleeping. But once your end tidal goes from 35 to 45 to 55 to 65, it's almost the equivalent of general anesthesia. I've been fooled by that. Oh, it's 2:00 in the morning. No, the kid's not sleeping. The kid's about to go into cardiac arrest.
Or
So I
their
think
work of breathing's improving. No, they're becoming obtunded and slowing down.
Correct. Or I don't hear wheezing anymore. Yeah, that's a silent check.
Because they're not breathing. One other PED specific indicator that should worry you is apnea. So periodic apnea in a baby who's either got RSV or sepsis or a head injury, just be careful there. Seizures, that's a pre-respiratory arrest condition. Peter?
Right. Yeah, the very last one, and someone sent me a video the other day, someone who said, I'm at this ER, I don't think they know what they're doing. And they sent me a video, which I still have, of the kid grunting. Okay. And I said, that's not good. That's, that kid, luckily, they ended up managing the kid with some recommendations.
With some high flow, probably.
Well, the kid ended up having some sort of inhalational issue.
Okay.
And he was grunting because of something that he inhaled. And so got Decadron, he got some racemic, and everything kind of opened up a little bit. They observed him, but they were just kind of telling the mom, kid's fine, not recognizing the sign of potential respiratory failure. With grunting is not a good sign, obviously.
So you brought up a really good point of the bradycardia in terms of trauma and hemorrhage. Here's a question I got posed recently by a colleague. do you pace bradycardic trauma patients?
No,
I mean,
they need blood.
they need blood.
Okay. Because I think somebody had been QA'd recently or something. There was a question of, do you pace a bradycardic trauma patient or a bradycardic hemorrhagic shock patient? And I didn't honestly know the answer. I said, I mean, if you look at what we're commonly taught is like, sure, you pace them, but I wasn't really sure. And that's why I wanted to ask that.
Why is the heart bradycardic in that case? It's because it's ischemic. There's not enough oxygen delivery to the tissues and to the cells. It's not responding to its own electrical impulses. I don't think pacing is going to do you a bit of good in that case.
Right. It's like
there's nothing
cardioverting
in
the
the heart.
septic patient. Yeah.
Right. There's nothing in the heart to eject, right? It needs volume replacement, namely blood, which is why we should be carrying
Yes.
blood.
Yes. And giving it early. Yes. Probably with a
And
life
giving it
flow.
early. Yeah, you said
This
it.
is
Thank
not
you.
an
Yes.
endorsement.
I endorse,
That's the
fully
way to-
endorse.
That's the way you get it in fast, for sure.
Yes. Yes. All right. We've been almost an hour. Any closing thoughts that either of you or both of you wanted to impart on EMS, emergency medicine, anybody that's going to be listening?
It's a big question. Peter?
Yeah, I now that I've been doing EMS for 15 years and a hospital for 25 years, something very clear as a parent here in the House of Medicine, and it's that the House of Medicine does not fully appreciate and understand what EMS brings to the table, and it's imperative upon all of us to continue to push the envelope to do these podcasts, because when you look at the typical ED physician, they just see medics coming through the double doors. They have no freaking clue what we do. And recently, this one story kind of exactly exemplifies what I'm talking about. We had a guy, he was in VF arrest. We dual sequentialed him, got him back. We get to the ER. The ER doctor comes in and says, "Why the hell are there so many pads on this guy's chest?" And my lieutenant says, "Doctor, that's dual sequential. That's what saves his life." "No, we're not doing that. Remove those from his chest right now." So of course we had to go do the smackdown and kind of explain. It's embarrassing almost that and now with antibiotics for sepsis, we've been doing it here forever, but in agencies who are not, you'd have to keep pushing and just recognize they just don't value what you do, and that's partly our problem for not actually going and educating them and letting them know what we do. So I think that has to change. And that's why the American Heart Association, all those guidelines are way off. They don't value us either.
Peter, that's analogous to your story of the surgeon who threw the bag of blood across the room once your paramedics brought the resuscitated patient in, right?
Exactly. 100%.
So I guess mine would be minutes matter, and our sickest patients' minutes matter. Okay. And if minutes matter, then it's the provider on the front line that needs to manage the early phase of that critical illness. That's number one. Number two, obviously kids have some meaningful differences. That's why Peter came up with his Handtevy app in the first place, is so that we could think about in a new and more simplified way what the dosing is in this child. But aside from dosing and some of the nuances, like Peter just mentioned, the grunting or head bobbing or apnea in babies, or the placement of IOs in the tibia or not. I mean, we can name a number of pediatric specific nuances. Other than those, the physiology and the order of interventions is quite similar between children and adults. And so if we can think about those in a rigorous way and apply the same principles we would, Jake, in your cardiac arrest patient to the child that you see the next moment, I think you're going to be a lot better off for it. I agree with Peter that pushing interventions further into the field and entrusting our EMS partners with the early phase of care, including all the things we talked about: blood transfusion, adequate and expert airway management, the new style of double sequential defibrillation that Peter's doing. All these interventions should be pushed out, should be studied. And Peter, credit to you for studying and publishing a lot of these things on your own. You're helping us advance the field. But I think I'm excited about every day when I get to work with transport EMS crews and help them think through these interventions and how to order them for kids in particular. It's a privilege for me to do it, and I'm excited about it. And I'm just grateful that you would ask us to be on the podcast. So if we can do this more, let's do it. Let's keep educating our folks to push interventions out closer to the time when we meet the patient out in the field.
Yeah, absolutely. I would be honored if you guys would come back on. This was amazing. thank you so much for coming on. Like I said, it's been a treat for me. Dr. Piehl, one quick story. You actually were my son's attending a couple years ago.
No way.
You met my wife. My son was admitted for severe dehydration and metabolic acidosis, and it was during COVID.
Did I get fluid? Did I get fluid?
Well, I think the ED gave saline and then switched to LR when his chloride came back elevated, I believe is what happened. But anyway, it was during COVID and we had our baby and I couldn't be there. My wife was there with him and she met you and she told you that I was a paramedic and you wanted to meet me and I never got the chance to. And that's
Well, here we go.
Yeah, and
Yeah.
finally,
Wow.
yeah.
What a great story.
Well,
That's a cool story.
yeah, doctors, thank you so much for coming on. I really appreciate it, and I hope we can do this again.
Anytime.
Thanks for
Thanks,
inviting
Jake.
us.
All right,
Appreciate
absolutely.
you
It's been a
guys.
privilege.
All right.
See ya.